Hello everyone, today topic is idiopathic intracranial hypertension, in other words IIH. The incidence of this condition is 1 to 2 people per 100,000 population. The median age is about is between 15 to 44 years old. The main risk factors for this disease is obesity, endocrine disturbance, medications such as tetracyclines, oral contraceptives, steroid withdrawal, hematological disorders, head trauma, and usually female are affected by these disorders. The pathogenesis of IIH is unknown. Looking at the clinical features, so the main complaint usually is headache. Patient can also complain about visual loss. Typically, visual field will be affected, rarely visual acuity. The other symptoms is transient visual obscuration, which usually can last a few seconds, and it can be associated with the posture change. So when patient is standing from the sitting position or lying position. Diplopia, which is double vision. Usually it is horizontal diplopia, so it occurs due to non-localizing sixth nerve palsy. Patient can also mention to you that whenever they lie down, they feel like a whooshing sound in their both ears, which we called pulsatile tinnitus. On physical examination, so on the fundoscopy, you will see papillary edema. You have a picture on the right hand side which shows papillary edema, which is bilateral disc edema due to increased intracranial pressure. So as you can see, the disc doesn't look like a yellowish peachy color. It is more pinky, and the margins of the optic disc are blurred. You can't see them. How do we diagnose IIH? So when you have a patient with all of those symptoms, first thing which you like to do is neuroimaging, mainly magnetic resonance venography. It is necessary to rule out intracranial lesions, venous sinus thrombosis before you are good to go ahead with the lumbar puncture. The next thing is lumbar puncture. By doing lumbar puncture, we can measure the opening and closing pressure. The normal range for opening pressure is about 10 to 20 centimeters of water. If it's more than that, it can be suggestive for IIH. Usually people with the IIH, they will have the opening pressure around 30 centimeters of water. How do we treat IIH? So the goal is to preserve optic nerve function while we're managing increased intracranial pressure. So the first line is acetazolamide, which is carbonic anhydrase inhibitor. It is also a sulfonamide derivative. It's important because many people can have allergic reaction to sulfonamide. So if a patient has a history of sulfonamide hypersensitivity, the acetazolamide will be contraindicated. Although acetazolamide is a good medication to manage increased intracranial hypertension, it also has a few side effects, such as hemorrhage, metabolic acidosis, nephrolithiasis, and abnormal sensation, which can be also contraindicated in some of patients with other associated disorders. The other thing is lifestyle advice. It is said that losing weight is a cornerstone of long-term management for IIH. Usually people who are diagnosed with the IIH, this is the first thing which is advised to them, and in the meantime, for a short term, they can have some medications prescribed to help with the symptoms. But losing weight is the best long-term management. If first line of pharmacological treatment is contraindicated, there is the second line of agents such as diuretics, topiramate, and corticosteroids, which can be considered. If for some reason visual function deteriorates despite maximal pharmacological therapy, the surgical intervention should be considered. And we can distinguish here optic nerve sheath fenestration, which is a protective measure to decompress fluid around the optic nerve, and for example cerebrospinal fluid diversion to help with the increased intracranial pressure. Okay, so I think it is just everything which is necessary to know about IIH. Let's have a look at typical case. So we have a 25-year-old female presented to her GP complaining of headaches, which she describes as dull ache all over her head. She says that initially headaches were short-lasting and on and off thing, but now for about 2 weeks they are constant. In the last 2 weeks, she also noticed that when she stands up from sitting position, and cough, her vision gets narrowed and she can't see peripherally. Moreover, when she lies down, she gets whooshing sound in both her ears. On examination, you see that patient has normal visual acuity, cranial nerves are intact, but optic disc looks hyperemic and margins are blurred. What do you do next? So, like in this case, we have almost all the symptoms which I mentioned before, which are typical for IIH. So there are headaches, which are for about 2 weeks constant. Before they were on and off. Patient has also visual obscuration, so her visual field is affected. She gets tunneled vision, so she can't see peripherally, and it looks like she's looking through a tunnel. She also mentioned whooshing sounds, which I mentioned before, and we call it pulsatile tinnitus. And of course, the optic disc on examination looks hyperemic and the margins are blurred, which means that she has papular edema. So what do you do next? And we have answers here. Lumbar puncture, commence patient on acetazolamide, MRV, check full blood count, perform fundoscopy. Although we use lumbar puncture for assessing the opening pressure, it is not the first thing you're gonna do. To do the lumbar puncture safely, we need to know that the patient doesn't have any intracranial lesion or there is no signs of venous sinus thrombosis. The next one, B, commence patient on acetazolamide. Although it will help with the symptoms, so with the managing of increased intracranial pressure, it is not something we can use for the diagnosis. MRV, so magnetic resonance venograph, it is the best answer because, as I mentioned before, by doing neuroimaging, we will make sure that there is nothing else which can result in increased intracranial pressure, such as intracranial mass lesion, or venous sinus thrombosis. Full blood count, that won't say much. It doesn't bring anything important to our diagnosis. And perform fundoscopy. So fundoscopy we've already done. We know that the optic disc shows papilloedema. So the answer is MRV. Hope that you will find this film useful. You have here all the necessary information about IIH. For now, I'm saying goodbye and bye-bye.